We are the Center for Advancing Health Outcomes. Research that transforms care, policy, practice, lives. Visit us at advancinghealth.ca.
So I'm going to be talking to you about a study that originated probably 5 years ago. And it's sort of the first of a broader project that we've had with a funding from NIDA. And so I'm excited to talk to you about it. I think it's something that BC should really be specializing in and leading the way in. And so I'm hoping this will open the floodgates, not just in substance use disorders, but other disease areas. So we're comparing buprenorphine naloxone versus methadone for the treatment of opioid use disorder. I have no conflicts of interest to declare. No, we've never taken any kind of industry funding. So I think that's an important thing to point out at the outset. And of course, our research was conducted in the unceded territories of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh nations. So, I debated how much of an introduction I wanted here. I think everybody knows the state of the overdose epidemic. We are losing this battle decisively. And I think, it doesn't benefit us to skirt around that fact. It is a fact, and it's what we do now that matters. Opioid agonist treatment with either buprenorphine or naloxone, these are WHO essential medicines, and they are perhaps our most important tools in combating the overdose epidemic. There's an interesting dynamic at play with buprenorphine since it was introduced in this province. So prior studies have demonstrated that buprenorphine has a greater safety profile. It is a partial agonist as opposed to methadone, which is a full opioid agonist. So that partial agonist property provides, it makes it more safe to take, less overdose risk, particularly in the early going. But it also has a ceiling dose effect. And in fact, when the treatment was rolled out in this province, I remember seeing it and seeing the discussion about making it a first-line treatment. I had never seen retention on buprenorphine naloxone in observational settings shown to be better than methadone. So it was kind of for me, it was a red flag right out of the gate, because the benefits from this treatment are all derived while people are in treatment. And so the real goal is keeping them there as long as possible. Opioid use disorder is a chronic recurrent condition, and the goals of treatment are long-term retention. A lot of people don't like those goals. They try to taper off. They want to become abstinent. Our prior work with the provincial data has told us that doesn't work very often. It's really only 2.5%. Back in 2012, we wrote a paper with an early cut of data that showed that only 2.5% of OAT treatment episodes end in a sustained, successful taper. So it's long-term treatment, and it's really retention that is the linchpin here. So we had strong evidence of greater safety for buprenorphine, but sometimes ambiguous results on effectiveness. We know very little on heterogeneity in treatment effects and key subgroups. And, the most important thing is all of our evidence for these treatments was drawn from the heroin era. We really have nothing out there, aside from some of our work that's come out, on the effectiveness of these treatments, the comparative effectiveness of these treatments for people who are using fentanyl, okay? And of course, fentanyl use is increasing across the continent. The story now is fentanyl plus benzodiazepines plus whatever else is out there. It's really that evolving drug supply, which is, really confounding our efforts to stop this crisis. And I'll sort of loop back to that point at the end of the presentation. So in 2017, we released new guidelines, and this province went out on a limb a little bit in making buprenorphine, naloxone first-line treatment. The recommendations were made on the basis of the better safety profile, the possibility of having take-home doses, which is really, a judgment call and a structural decision that we've made. We have done take-home methadone for a long time. Not many people get it, but we know it's safe, it works. And ease of medication switching. These were that was the core argument for making buprenorphine first-line treatment as opposed to methadone, which had been first-line treatment here for ages. Since we started the study, we published a protocol back in 2020 and 21. Some of the guideline developers are co-authors of you notice the long list of names on the front page. They knew this study was coming. Both methadone and buprenorphine are now listed as first-line treatments, okay? We know opioid agonist treatment works, and we know it still works even in the fentanyl era, okay? So early on in this project, we showed that, in the purple line, mortality, the risk of mortality on treatment has not changed, surprisingly, reassuringly, I would say. But once people drop off of treatment, you can see that risk of mortality has really increased. And almost linearly with the rise of the prevalence of fentanyl in the illicit drug supply. That's really what's driving the bus here. There's really no two ways about it, but OAT protects against mortality even in the fentanyl era. Unfortunately, retention on OAT is on a 13-year decline now. 13 years straight, we have seen declines in 12-month OAT retention. Okay, so the three lines, can you see my cursor? Yeah, the three lines that I'm showing here are, basically definitions of how you describe an OAT episode, whether a break of 30 days or 14 days or 5 or 6 days are used. What we're showing here is no matter what definition you use, this is declining. On the Z-axis here, we have the total number of OAT episodes that were initiated in each of these calendar years. And you can see that going up, and you can see that a lot of the rise is attributable to people starting buprenorphine naloxone, okay? So we've expanded access. I think the province has gone to great lengths to expand access, draw more physicians into this subspecialty, yet we continue to see poor results, okay? I like to think there are three reasons for this decline. First is, of course, a more potent drug in the illicit drug supply. It's taking more and more to eliminate withdrawal symptoms, and our dosing guidelines, our medications haven't really kept up, okay? Second is, it's an artifact of this increase in access. We're reaching out to more and more marginalized people who would have been poor candidates for retention in the first place. And the third is the introduction of buprenorphine. So right from the outset, buprenorphine had poor retention and treatment, okay? The red line is buprenorphine naloxone, the blue line is methadone, and the green line is other. This is a bit of an older plot. As time has gone on, these lines have converged a little bit, but at no point has retention buprenorphine naloxone ever exceeded methadone. In fact, not even close. That said, we can't draw that much of a conclusion from just raw data, a univariate comparison, okay? So this is subject to confounding by indication, which is really, potentially different types of people accessing one form of treatment or another, and time varying confounding. So perhaps buprenorphine isn't used appropriately, right? People aren't following dosing guidelines. In fact, that's what we saw in the early going. I think it took prescribers some time to get used to the medication. But we've known this for a long time. We've shown this slide to the ministry, the health authorities, We've shown it a million times. This has been well known. I think we came up with this in 2018 is when we started showing this slide. Okay. So we need to get to the bottom of this, and we need to, as strong a direct comparison against between these two treatments as possible. So our objective is to determine the safety and comparative effectiveness of buprenorphine naloxone versus methadone for the treatment of opioid use disorders. And we're doing this using population level linked data. Our linked data in this province is truly second to none. That's not hyperbole. There is no other jurisdiction in the world. And maybe I'm looking over to Jason just to confirm that. I have not seen it, not in this population, where you can get as much information on individuals linked together as you can here, okay? So it's a great resource. We need to be using it more. If you take nothing else away from this talk, is that we have this amazing resource where it is underutilized. We need more people, more trainees working at it, not just in substance use disorders, across the board. Okay, so our methodological approach, of course, randomized control trials are the gold standard. Nobody's going to argue that. There is no observational study whose validity is going to be greater, internal validity that is going to be greater than an RCT. Okay, nevertheless, RCTs have a lot of drawbacks. Okay, there are issues with external validity. Often RCTs draw a specific type of sample. There are strict inclusion, exclusion criteria, and the type of person that volunteers themselves for a trial, particularly for something like this, is different from somebody out there in the general population. There are issues with timing, there are practical constraints and ethical constraints. I can tell you, I think 3 out of the 4 RCTs that I've been involved in, by the time we got an answer from the trial, the field had moved on. It was a moot point. And so that's my personal experience over 20 years in this business. And so I'm really keen on doing the best that we can to emulate trials with observational data. Okay, I think it's I think we've made some pretty significant advances in this area in the last 10 years. It's really the lead epidemiologists at Harvard that are pushing this. I think we should follow that lead. I think it's an excellent thing to pursue. So nevertheless, without that coin toss, we can never be sure about unmeasured confounding, right? Any kind of inference we make, this is necessarily an inductive process. It's not deductive, okay? We're not deducing an answer from our data. It's an inductive process. But with our analyses, we can build in some elements of logical deduction by ruling out incorrect results due to misspecification, omission of known measurable confounders, basically errors that we're making on the analytical side. And you'll see that, this presentation is like more methodologically oriented than clinical, just because that's who I am. I think there are elements that we can build into these analyses that make us more confident, right? Our approach, our goal in our team is just eliminate subjectivity as much as possible. Any form of subjectivity that you impose in the design stage, you can always address that one way or another. Oh, that didn't. Okay. So a well-designed observational study can mimic the results of an RCT. It can, right? And emphasis on the well-designed, okay? This is a study by, Ioannidis and his colleagues. They've compared results of RCTs with similar observational studies, and with strict exclusion criteria for the observational studies, it's been shown that these can mimic the results. If that's the case, we need to do the best that we can to do as many of these kinds of observational studies as possible, because, aside from the practical constraints of doing RCTs, they're super expensive, right? And they're time consuming, right? So I don't know if you've heard about target trial emulation or target trials. It's sort of a new methodology that's blowing up, basically. In the past couple of years, the amount of, I sit on an NIH review panel, the amount of applications that I've seen in the last 3 or 4 cycles citing target trial emulation is like exploded. Okay, so this is something that we need to catch on to, get on board with. The beauty of this is in its simplicity, really. Yes, the analytic approach is a little involved, but the basic design, why wouldn't you try to mimic the design of an RCT if you had an observational data set? It's really simple in its conception, okay? So there are, of course, constraints. We cannot emulate trials with blind assessment. Obviously, you can't do you can't emulate a blinded trial, double blind, single blind. We can really only do pragmatic trials, which is kind of what we need to be doing anyway. I think there are plenty of good examples, regardless of those constraints, that make this a really useful methodology. A big constraint, if you're only looking retrospectively, is that you can only make comparisons based on things that have already been done, right? Standard clinical practice, okay? That is not a binding constraint. You can overcome that, right? You can design a prospective study, non-randomized prospective study, and apply this methodology, okay? So the first step in doing this and doing this well is publishing a protocol. And I think, now that we've kind of gotten into this rhythm of publishing protocols for comparative effectiveness studies, I don't think we're ever going to go back. I mean, aside from the obvious, like, reductions in type 2 errors, analyst reductions, data mining, if you are supervising students, if you're a student yourself, it's a really good teaching aid, right? It puts all of the design thinking ahead of everything else, right? And so, this was a good experience writing this protocol. We've written a series along this line since then. I think it's particularly great for trainees to think about publishing protocols for their studies ahead of time. The key quote in this protocol here is that any changes that we make to the protocol are going to be identified as such in the final reports. And we have done that. With all of our papers in the series, we now have a paragraph just before limitations where we talk about deviations from protocol and why we've done it. And then we include a big table in the appendix, okay? So again, back to our data sources, we have linked provincial health admin data. We've been lucky. HISCR has supplied us with this data from 2017, 2018, and updated our data roughly every year or two. We have a sort of informal role as providing analytical support to Ministry of Mental Health and Addictions and the health authorities, FNHA, using these data. It's something that I'm very grateful for, and I like to think we've made good on our end of the bargain. This is just, these studies, these target trial studies that we've been doing, this is just one piece of a larger puzzle. So we've really tried to provide intelligence where we can. As with anything, anything pharmacoepidemiological, PharmaNet is really the crown jewel, and it's a crown jewel in the linked health admin data ecosystem. It's what separates us from places like Massachusetts, which also have a great linked data system, but they don't have daily, dispensation level data for medications for the entire province. That is what makes this linkage unique. It's a real amazing thing. I was lucky enough to get access to this data when I was a PhD student. And so I've had lots of time, lots of experience working with it. It's pretty much my entire career doing this. Our design is a retrospective population-based study of everybody who's received buprenorphine, naloxone, or methadone, who are over 18 and not incarcerated at the time of initiation, and who are not pregnant or in palliative care or cancer care between 2010 and just before the pandemic. We struggled with the cutoff at the pandemic. In the course of the study, we got access to new cuts of data, but at that time, a lot of different things changed at the same time. And we felt like, you know, to keep things clean, let's cut it off here. It probably means we're gonna have to go back to this and redo this at some point, which is gonna be painful, but, you know, I'm sure we'll have a keen new student to take on that painful exercise. So our exposure is receipt of buprenorphine or methadone, and we're analyzing this in weekly time steps, okay? So time from initiation to discontinuation, which was 5 or 6 days off of treatment. Why 5 or 6 days? Because in our clinical guidelines, they say after 5 days off of buprenorphine, 5 days off of methadone, they should revert to their starting dose. And that rule is 6 days for buprenorphine. So, I mean, that rule is, you know, that's another one of our target trials to assess that rule, whether that's correct. But it's the, you know, it's the only objective criterion that we could identify. Otherwise, we're just, you know, making up something arbitrary, right? Which is what most people do in the literature. We've generated, our primary outcomes are treatment discontinuation, as I just said, and all-cause mortality, okay? Covariate control was informed by a systematic review, okay? So in that protocol, we did a systematic review to identify determinants of these outcomes. And from a list, and the list is published in the protocol, we were able to determine which covariates we had, which we didn't. And we added to that based on context and the other information that we had available, okay? Wondering how I'm doing for time here. Okay, not bad. So, you know, emulating an RCT, it really starts with this table. So you have a target trial, and that's the left column. And either it's a trial that has already been conducted, or it's an ideal hypothetical that you can think up for this comparison. So in this case, you know, I think we had a trial in mind. It was a composite of a few that were included in a systematic review. So I didn't think this was a particularly controversial or challenging trial to design. It's a simple intent to treat comparison between two medications. So it's really, you know, emulating the trial is really fulfilling these 6, 7 conditions here. Establish your eligibility criteria. Your assignment procedures, of course, in the trial, you have randomization. With observational data, you can use different techniques. If it is an intent to treat or an initiator design, it's propensity score matching, okay? Your treatment strategies, you can, you know, we have some more specifications, but that is done exactly the same way. Time zero is really, you know, and this is something that we realized in peer review. We cannot do a true intent to treat, okay? The intention, right? When the prescription was written, I mean, we don't have that. We have when people initiate treatment, okay? So there may be, and you know, we're trying to get to the bottom of it ourselves. There may be instances where people have a prescription written. Basically, we can see an MSP when a billing code is used for an initial assessment, which usually means treatment is indicated. Sometimes people don't follow through on that. A lot of the time, you know, and the question becomes, is it differential between treatments? It really shouldn't be if there's, you know, if the decision is made jointly with the prescriber, but we don't know that. Oftentimes, I think it's, you know, people just having a hard time and chaotic lifestyles and, you know, anyway, it's really a conditional statement, okay, that we can make among people initiating treatment. This is the comparative effectiveness, and we can do, we set our follow-up period, we name our outcomes, and even the statistical analysis isn't necessarily all that different. Even in an RCT, you might want to control for post-randomization bias due to dropout. So you might use a lot of these techniques anyway, okay? So more on some of the design considerations. First, we considered both incident user and prevalent new user designs. I hope this language isn't too out there. It's kind of specific to this methodology. Incident users are first-time users, naive to treatment, okay? And we can establish that pretty well because our data goes back to 1996. That said, that is a small fraction of the people accessing treatment at any given time. So, generally prevalent new user designs are not preferred because, in a lot of settings, you might not necessarily be able to control adequately for treatment history, but we have all of that. And if you don't do a prevalent new user design, you're really throwing out most of your data, right? In any given calendar year, the blue bars are incident users and the red bars are, all of the repeated episodes. So it's a real shame to only do an incident user design. And it doesn't really, we're then not providing much guidance to clinicians who are pretty rarely seeing incident users. Most of these clinicians who are seeing patients, these are people who have come back for treatment multiple times, okay? So we've done it both ways here. We are also doing an analysis two different ways. First, an analog to an intention to treat design, which is straight comparison, only controlling for baseline confounding by indication and going from there. And also a per protocol design so that we can compare treatments delivered at optimal dose. Remember when I showed you the retention slide, we said, we can't make judgments on this univariate comparison because they may be different people fundamentally at baseline when they enroll, and the medications may be used differently, okay? So that's the rationale for these two different designs. In each of these, we've tried to do multiple analytic methods. Again, just to make sure that our results aren't an artifact of just the way that we did this, okay? So in initiator analysis, the typical way of doing things is by propensity score matching with investigator selected covariates, okay? You can also do high dimensional propensity score matching using extra data that you get mostly out of hospitalization records, and it's mostly capturing, unmeasured confounding due to disease severity, comorbidity. We also did an instrumental variable approach, okay? So the key thing to know, differentiating these approaches, propensity score matching, presupposes that all of your confounding is measurable, okay? Instrumental variable analysis is the opposite. You assume that there is unmeasured confounding, okay? We don't actually know. That's an untestable hypothesis. We don't know a priori whether there is or there isn't unmeasured confounding. If we do it both ways and the results are concordant, we're confident that it's not an issue. We're more confident in our inference, not certain, but more confident. Our per protocol analysis basically, I'll get into it a little further on here. There's a lot more to say about instrumental variables. We wrote it up in a paper in epidemiology a year ago, 2 years ago. This methodology is controversial. It's not very well liked by epidemiologists, and for good reason. I think there's good reason for that. This originated out of econometrics. I came up through economics. When I was in grad school learning about instrumental variables, it was kind of, it was very hand wavy and it was never very satisfying, right? It was always like, if you find this magic instrument that is associated with treatment and not the outcome, all of your confounding by indication, or as economists call it, endogeneity, or as we used to call it, selection bias, it magically disappears. That's not true. All of the early econometric studies using IVs have since been debunked, but there is value in this. And, I'll just say there's a reason why it's a secondary analysis and not a primary, okay? If you're interested in this sort of thing anyway, you can look up our paper. It was a really mixed methods evaluation of choosing the best instrument for this analysis. And we're gonna continue to do this in any IV papers that we do. The per protocol analysis was really the challenging bit. Zhong Min, our lead statistician, isn't here. Zhong is probably suffering from PTSD from all of the iteration that we did on this methodology, okay? So initially, we thought this was going to be a G estimation application, okay? So a structured, nested, accelerated failure time model is what we first investigated for this. About 3-4 months in, we realized we went back to the original paper where we got the SAS code and saw that actually the methodology had never been tested with a true big data set, and it's really an experimental method. And so it was one of these moments like, oh no. We found another methodology called structural nested cumulative survival time models. We tried that. We actually reached out to the lead author of that methodology, Sean Seaman. He was overjoyed that somebody had found an application that could use his methodology. But on further discussion, we realized it didn't actually fit, right? So that, this is all based on an interaction. So it's not just treatment, it's treatment at optimal dose. So it was really that interaction term that made us feel that G estimation was the right approach. The problem is dose is internal in that process, right? There's no treatment without dosage. And this methodology only works for an external variable. So if you're contemplating G estimation, I hope I just saved you 6 months of pain and suffering. Ultimately, what we settled on was a marginal structural model with censorship at the point of deviation from recommended clinical practice. So we kept people in so long as they stuck with dosing guidelines. As soon as they deviated, they were excluded from the study, okay? So I have a diagram describing time varying confounding here. It's from a different application, but basically if you think of exposure as dose and outcome as retention, if you get a higher dose, you're more likely to be retained in treatment. But the longer you're retained in treatment, the more likely you are to get a higher dose. And that is the sort of circularity, the time varying confounding that you want to control for in this kind of analysis. Otherwise, you're conflating things and you're overestimating the effect of dosage, okay? There are also some other intricacies in doing this kind of work. This isn't really, I don't want to discourage people because we really need more people doing this sort of thing, but this is not really for the faint of heart. There's lots more to learn about how to do this and how to do this well. So we also adjusted for censoring due to the end of study follow-up, meeting non-eligibility criteria, right? People aging out or getting pregnant or going to jail. And in the treatment discontinuation model, we also adjusted for death. We also did some more sensitivity analysis combining that outcome, okay? So lots more to say on this. I probably dwelled on it longer than I should have. Just, for future reference, this is a wide world that's still in development here. I'm a big believer in sensitivity analysis. Again, you don't want to impose, you don't want your results to be an artifact of some design decision that you made. And so we did extensive sensitivity analysis. I haven't really seen a good methodological paper on sensitivity analysis. We came up with this list ourselves. I think it should be out there. Basically, we think about sample restriction, looking at subgroups, timeline restriction, thinking about post-fentanyl, other kind of policy changes that happened. variable reclassification, like our rule for treatment discontinuation, 5-6 days, are our results just based on that rule, right? We can change all of these things. And of course, using different methodologies, different regression methods. We don't want our results to be an artifact of how we did them, okay? Probabilistic bias analysis is another thing that we've done. I don't know if you've heard of E-values. They're out there. People don't really like them. We had a bias analysis included here and the journal wanted it out, so it's not there anymore. So we had a huge data set to work with, okay? So we started with 252,000 OAT episodes. We excluded a lot because of we had a washout period in our prevalent new user analysis, and it's a common thing to do. So a lot were excluded there. So more were excluded on the inclusion exclusion criteria. We were left with 97,000 episodes among 40,000 unique individuals, 97,000 prevalent new users, and 30,000 incident users. Lots for both buprenorphine and methadone. We had more exclusions in the per protocol analysis where people were off track right from the outset, right from week 1. And so they couldn't be included in per protocol analysis. But I mean, these are extremely well-powered analyses, both the initiator and per protocol. Okay. Covariate selection, I told you this was informed by systematic review. Our covariate control was extensive, and we had lots of fixed covariates that we controlled for a baseline and lots of time varying covariates that were able to change from one week to another, okay? And so if you think about, I'll focus on the treatment course. It's not just daily dosage. And again, the time varying covariates, these only apply to the per protocol analysis. An initiator analysis only controls for baseline covariates. But the time varying covariates, they could change from one week to another. And we controlled for things like receipt of take-home doses, urine drug testing, and of course, daily dosage was the key thing that we wanted to see, optimal dose or not. Okay, so we control for all of these things that might make it more easy for people to stick with or more difficult. Right into the results. So on the left, we have our adjusted cumulative incidence curves. So instead of a single hazard ratio, you can think of this like a comparison over time. It's not a simple Kaplan-Meier curve, it's an adjusted comparison. But you can see, the cumulative incidence of dropout for buprenorphine was higher almost immediately. You can see it within the first few weeks of treatment, people are dropping out more. And that's where a lot of this dropout happens within the first 3 months. After that, it sort of stabilizes, but really resounding result. We had the risk of dropout was 58% higher for buprenorphine compared to methadone. In initiator analysis and per protocol analysis, it was 67% higher. It wasn't that different between incident users and prevalent new users. I mean, this is a resounding result. And what really kind of surprised me was just how stable this result was in different patient subgroups. I really expected to see, for instance, youth to respond better to buprenorphine naloxone. I thought, yes, bup is a partial agonist, but youth should have less severe addiction severity. And so maybe it works better for youth. And I think that was, a common, I guess, misconception now out in the field. So you can see our baseline results for the intent to treat initiator analysis and the per protocol. You can see among people with comorbid pain, youth under 24, people with severe mental disorders, people with a history of incarceration, people who had, it's not perfect, but it's basically an indicator of iatrogenic dependence, people who had prescription opioids before they got onto treatment, prescription opioids at higher dose or longer than recommended. and in the fentanyl era. The only result that we saw no significant difference between the treatments were from physicians who were on the alternative payment plan. So these are community health centers. And what I think is happening here is this is the lowest threshold methadone that's provided. It's more methadone than buprenorphine. And so this is a very low threshold treatment, and retention was very low for both groups. So, and this is with all kinds of exclusions. The results were amazingly stable, okay? So this is the full list of sensitivity analyses that we did. Sample restriction, timeline restriction, variable reclassification, and model specification. You're not gonna, sorry, this is a very busy slide. All I want you to see here is, this is our baseline result. Oh, and you can see just how stable the results are here, okay? This was our alternative payment plan analysis. This was the outlier, the one that was closest to parity. I'll point out the instrumental variable analysis is here. So there is some difference between our propensity score matching result and our IV approach. And maybe you can say, that's a signal that there was some unmeasured confounding. I mean, it's a magnitude difference. Both are strongly still pointing in the direction of methadone here, okay? Mortality, slightly different. Again, we expected to see mortality favor buprenorphine, right? There's no doubt that it has a greater safety profile. We didn't necessarily see that result, okay? So cumulative incidence curve here, the higher the line, the higher the risk. So within the first 3 months, buprenorphine naloxone had a lower risk of mortality, but that changed afterwards, okay? Now, the average effect was about equal, okay? I don't want to say equal. We want to be careful about how we're interpreting confidence intervals. The point estimates in our per protocol analysis still favor buprenorphine, but in an initiator analysis, they were equal for incident users, and it is fair to say equal, it's right on the line. And it actually favored methadone in prevalent new users. So we have to step back and think about this for a second. So the initiator analysis doesn't condition on treatment. So this is from when treatment started until death. People could have discontinued along the way. It's no longer an initiator intent to treat analysis if you condition on treatment access. So what this is saying is that, once people drop out, they're at a higher risk of death, okay? And, while people are on treatment, which is the per protocol analysis, it's roughly equal, okay? Okay, and again, really stable results. These are all our subgroups. You can see our baseline analysis and just how stable this was throughout. Where things deviated a little bit, it's kind of interesting, is a high dose comparison. High dose of buprenorphine greater than 24 milligrams versus high dose of methadone greater than 100 milligrams per day. We did not think about this at the protocol stage. This was a deviation from protocol. It's something that we added after the fact. It's a shame. We just didn't think of it. Also, I want to point out the numbers are extremely low here, right? In general, we saw very few deaths on treatment, right? Treatment is really effective in keeping people from dying. The key is just keeping them on. So some protective benefits for methadone at very high dose, but not enough for us to draw any hard conclusions on that. I think if we are going to go ahead with buprenorphine naloxone, it'd be crazy to dose this at less than 24 milligrams per day. It's more like 32. And for prevalent new users, again, amazing stability across all kinds of, different analyses, different sub-analyses that we did. So these were our deviations from protocol. We changed some inclusion criteria, and that was really cancer palliative care. At some point along the lines, we realized, wait, we've got a fair number of cancer patients. These are different people. We need to exclude them. A lot of this could be extra pain control. They shouldn't be in this comparison. So we deviated. I already told you how we changed our analytical approach. It was a trial and error, a painful, probably 15-month trial and error, fortunately. But we got there. From there on, it was mostly just adding sensitivity analysis, more things that we came up with and we thought of just to ensure that our results were stable and correct. We had some limitations, as in any study, on our mortality analysis, even though we're dealing with a population level study and it's truly everybody in the province receiving these treatments. We still had small numbers of deaths on treatment, particularly among incident users, okay? Measurement error, our secondary outcome, I didn't dwell on it much, but our secondary outcome was acute care visits. That's problematic, and we've seen it crop up in some of our other papers. We've looked at all-cause acute care visits, drug-related acute care visits, or overdose-related acute care visits, and we see the signs changing between drug-related and overdose. I'm still trying to figure out what that's all about. I think a problem here is that people are using emergency room as though it's outpatient care, and I think that's primarily what we're seeing here. Confounding by indication, of course, we can't. This isn't a true intent to treat. We don't have that intention. People may have been assigned a treatment and decided they didn't want it and didn't show up, or they were assigned a treatment and just didn't make it to clinic on time. Okay, I think you need EMR records to sort that out, and I'd like to pursue that if anybody has access. Nevertheless, we did a lot to control for confounding by indication. And we got consistent direction across our methodological approaches with different assumptions on selection. External validity, BC, Canada is different from the US, different in a good way, and I'll get into it in a second. I think we draw a deeper pool of people into our treatment system, which is a good thing. I think in places where it's more restricted, you have more motivated people, people with families driving them to clinic, basically. So that's a little bit different. And these medications are available in both doctors' offices and specialized drug treatment centers. In the US, you can only get methadone in specialized drug treatment centers, which is why some of this is an important result for the US in particular, why NIDA was interested in funding this. So bottom line, methadone demonstrated superior effectiveness in retaining people in treatment, and it wasn't very close. It was a really strong result. Slightly less pronounced in prevalent new users, but retention is poor and declining overall. So we really need to think about how to address that. Risk of mortality in treatment was low across treatments. The initiator analysis among prevalent new users favored methadone. And again, this is because people are dropping out of buprenorphine faster and being exposed to street drugs, and they're dying from street drugs. And there's maybe more to do at the comparison at high dose. Our results were amazingly consistent across subgroups of individuals and across all our sensitivity analysis. We still have these sort of perhaps diverging results on retention mortality, and that's something that we considered further. We plugged these results into a simulation model and considered different states of the world where we only had access to methadone and only had access to buprenorphine. And if you do that, only one versus only the other comparison, I mean, introducing buprenorphine, it killed people, okay? I think we have to be honest with ourselves about that. The way that we've done it, it contributed to the overdose epidemic. More people died as a result of the introduction of buprenorphine naloxone. So this is something that's coming out again. These are two analyses. They don't have perfectly concordant results. How do we reconcile that? Well, we can plug them into a simulation model and calculate total life years gained in different states of the world, okay? So the implications are different in the US versus in Canada. In the US, again, you don't have methadone available to people from office-based settings. That's crazy. A lot of Americans know it. We've given them some ammunition to change their laws. And this Senator Markey was interested in our results. They posted a notice when our study came out a month ago, and we're hoping it's going to change things in the US for the better. And that's a great feeling. Locally, this is just about our treatment guidelines and where we go from here, okay? So there are other extensions. We're using this methodology right now to answer a whole host of questions about how we do things for people with opioid use disorders. That starts with medication selection, but it's also, what rate we titrate, how frequently we do urine drug testing, what we do after people have a treatment interruption, when people should start getting take-home doses, what duration of take-home doses we can get. You can imagine there are a whole host of different questions that we need to answer. And most of these rules, most of these recommendations are really supported by weak evidence. There's no other way to say it. A lot of it is clinical judgment and not coming out of RCTs. I sit in two worlds, in HIV and substance use disorders, and they couldn't be further apart in terms of the underlying evidence base that we have to support these kinds of decisions. It's amazing how different they are. Amazing how barren substance use disorders is, even today. So this is our sort of pipeline of target trials papers. And this, I really want to give a shout out to our excellent students. Some of them are here today. Our second paper is under review right now. Third paper is just about to come out on time of tapering initiation. We've got 5 protocols about to go out, led by all different students in our group. We have received funding to do, I didn't finish those, sorry. People with concurrent schizophrenia and concurrent bipolar disorders. There are all kinds of questions about what medication regimens to use there. I mean, mental health, like it's amazing. All of these RCTs that have been done for medications for mental health, they unanimously exclude people with substance use disorders. So we are flying blind, essentially. So there's lots to do there, and we're also doing this for treatment comparisons for pregnant women. Initially, we thought of that as a sub-analysis in this paper, and we realized it's a whole different can of worms. There are effects on children that require different designs, so it didn't make sense to include them. The last bit, and unfortunately it's cut off, but it's okay, because I've got new slides for it. We're working with our colleagues at the BCCSU to pilot test new novel therapeutic regimens and do this prospectively. Again, this kind of analysis isn't restricted just to retrospective analysis. If you can convince some clinicians to go along with you to test new novel regimens, you can do this prospectively. So, an issue that we're hearing from clinicians here at the hospital is that people are showing up, and it's not just withdrawal from opioids that they're suffering from. It's benzodiazepine withdrawal. And benzos are a whole different can of worms. They don't know what to do with them, right? These are designer benzos. They're not prescribed. And, typically with benzodiazepines, you want to do a long taper. But you don't want to risk doing a long taper for these clients because you don't know the level of dependence. So they're testing totally new very short tapers for benzodiazepines. And basically, there are a lot of different strategies that we need to be considering right now. Again, it's not like methadone works very well and its effect has been stable or improving over time. It's declining as well. So we need new strategies, and this is a good method. I mean, I don't think we can do an RCT in this domain. I think with the rate at which the illicit drug supply is changing, we need to be trialing new things and considering these things as we go. So we're trialing this in 6 racks across the province. This is what we've proposed. And our control group is going to be everyone else in the province receiving the current standard of care. Okay, it's the same methodology that we'll be applying. Again, I want to acknowledge our excellent team, the trainees, many of whom are leading some of these subsequent papers. Among our staff, I just want to give a shout out to Micah Pisk, who's with us in the audience. She wrote the original protocol. This is her last day with us. She's moving on to the Ministry of Health. We are going to miss you, Micah, but you're going to do great at the ministry. Congratulations. We've also you noticed at the beginning, we had a very long list of co-authors. I think that's a positive thing. We have purposely tried to bring in lots of different perspectives, both clinical and methodological, in the interest of, we want to have different perspectives on this. We want to approach these problems from different domains. And we want to make sure these clinical leads were chosen because they had a hand in writing up clinical guidelines in the past. So we want to use them as a pipeline to get our results into clinical guidelines as quickly as possible. We're grateful for them. The amount of feedback, the quality of feedback we've received from this gang has been unbelievable. So if anybody is on the line listening, thank you very, very much. And of course, all the data stewards and everybody around us who has allowed us to access this data, thank you. We hope we're doing justice with this.